the S&C coaches and their exercise professionals to get the best out of them. I don't want them to be reliant on me all the time for their strength and conditioning. I think it needs to be proactive. They need to take some ownership of it. They also need to be directed by the appropriately trained people. And if we as physios hold on to our patients for too long, we're not going to see the best outcomes.
That's perfect. Like that. Like I just put it live just because I wanted to catch this, because it's just such an organic conversation we're having. And I think it's this disconnect between the early stage, middle stage, and end stage.
Yeah.
Okay.
Yeah.
And you're getting some awesome physiotherapists who are now, they're building a skill set and qualifications, and they can do both. They can do the early to the end, which is amazing.
Yeah.
But I mean, correct me if I'm wrong, but from what I'm hearing from physiotherapists is often there are quotas that physios have to hit when they work in facilities. You have to hit multiple times, 2-3 times per week for these first 4-week block, then blah blah blah. So the outcomes are less about getting the results as quickly as possible, more about money and retention. What are your thoughts on that?
Yeah, and I had some experience with that in a previous clinic where it wasn't necessarily a quota, but there was some expectation that you'd see a person, X amount of times in a given time frame. But I know there are some other practices where it is, you've got a bare minimum. There is a business perspective to it, and the practice manager or the business owner would want you to see them X amount of times per week for X amount of weeks, depending on the injury, depending on a number of different factors. So it does exist, and it's a shame. I'm lucky enough to work in a clinic here in Melbourne where they don't have those key performance indicators or KPIs. All they want you to see as a bare minimum is you see them for the first time, and if importantly you see them for a second time to make sure they're getting better, and so you can plan them. And if you don't see them because they've just got better and resolved on themselves, that's great. But make sure you follow up with them with a phone call or an email to make sure that's their expectation. So, which is great, and that really is how it should be. That person needs to be seen really as many times as they need to be seen, not 10 times in the first 5 weeks or 4 times in the first 3 weeks just because you got to meet some business quota. It's a business model. It's not necessarily a good physiotherapy model from a patient perspective. And I think ultimately we sometimes forget that we should be trying to get the patient better and get them to take ownership of their injuries and their rehabilitation to drive their own recovery, because they need to be front and center of our decision making. They need to be part of that decision making as well. And I think if we get them too reliant on us, it's not a great thing for their own self-efficacy in the future, and I think sometimes it can actually reinforce some chronic illnesses because they don't know how to get out of a hole when they're in hole. They don't have those problem-solving strategies or the coping strategies to get out of them. They always, get sore or get injured, and they go running back to their physio for hands-on treatment or whatever it may be. I think we need a little bit more. Here's the skills to get you out of it, and here's how we're going to rehab you so you can take ownership for yourself in the future. Of course, we give guidance along the way, but yeah, I think, I guess to answer your question, there is certainly some sections of the physio community that does have KPIs that are quite quota driven.
How do you then bridge the gap between, because you're essentially saying, and it's something I say to my clients, like, I want to make myself redundant. I don't want you to be reliant on me. And it's from a business model, it's dumb.
Yeah,
right?
It sucks. Yeah, I'm the worst from a business perspective. I'm the worst physio in the world.
Right.
I see a person. Like I'm like you. I think it's important that we become redundant after a while, and that's a great skill in itself. If you give that person so much knowledge and information that they can do that on their own, that's a powerful tool to give. And that's where I think we all should be striving to do that. I'm terrible at maintaining a list, and saying, or I can maintain a list. I'm seeing patients and all that kind of stuff. But in terms of KPIs, my KPIs suck. But I'm happy with that. I like seeing a patient once, And often now at the moment, I pick up a lot of tricky cases. I see patients who maybe 4 months down the track, 6 months down the track after an ACL reconstruction, and are struggling because they're struggling to run, they're struggling to jump, they can't foresee any future where they'll be training or playing sport, and they're frustrated and they're in a hole, and to take them through a consultation and say, look, these are the reasons behind why you're probably struggling. It might be a weak quad, it might be poor balance, it could be poor overall lower limb strength, it could be a number of different factors, but we identify those weaknesses and we try to get them out of that hole. And importantly, I want to give them the tools to try and get out of themselves rather than supervise them through the next month, twice a week, for 4 weeks. So I want to give them a program, I want to give them a plan, and I want to also get an appropriate exercise professional to help them along the way.
For sure.
Because most people need a good gym program if they're coming to see me. And what matters the most is, because if they're coming to travel to see me in the city, yet they live out in the southeast suburbs or they live up in the northern suburbs, access to me is going to be quite difficult if they have to come in twice a week. So importantly, I want them to work with someone that's convenient to them, but also is expert in their given field as well. So knowing where these health professionals live around for us in Melbourne, if I've got a patient who lives in southeast suburbs, I want to be referring to exercise professionals down there because I know they'll be able to get to them for consistency. I'll see them twice a week or once a week or however many times they need to do. I've got a patient up in the northern suburbs. I'm going to send them up there to a local person up there that I know is going to give them that consistency. I think consistency is really, really important when it comes to a lot of training.
And I noticed you also mentioned that I wanted to bring up a great point. Like, how do you teach your clients, your athletes, basically the self-awareness, the tools? You said you want to give them the tools. What is the most effective way that you've found to give people the tools to learn body self-awareness, to learn how to manage their own injuries, pain, and ailments?
Yeah, well, I think a lot of it's a great question. And it would probably differ a little bit from person to person, but I think so. It's a lot of feedback, both verbal, visual feedback. Like for example, someone who's not landing very well. They're 6 months post-op. They're trying to run, they're trying to jump, but their knee gets sore. A perfect example for this would be, let's get them to jump and land either with a video camera in front of them filming them so then you can replay the footage, or let's get them to do it in front of a mirror and let's talk them through why they're getting some of their pain. So I think certainly some verbal feedback, some visual feedback is really important, because if they're landing really stiffly on that affected leg, and it's like giving them almost like a jarring sensation, or they're hinging at the hip to help absorb that force, and that's very different from their uninjured side. And that's almost like the light bulb moment as to why they're getting some pain. It's like, okay, how can we help you shock absorb better to dissipate that load better? And then you take that one step further for this person, for example, and you go measure their quad and you get them to do a 10 rep knee extension test, or you measure their quads and it's like you're 30% down here. That's the reason why you're not shock absorbing well and why you're cheating at the hip and why you're jarring that knee. So if we address your quads, you'll feel more confident when you land, you'll land more smoothly, and then you take it from there. So you try to, I guess, rationalize why they're in their pain, through either weakness or strength or lack of flexibility, lack of range, swelling. You try to find answers why, and I think it's lots of communication, lots of feedback. That's one way I hopefully get people to buy in to their rehab. And ultimately, you need to find out what their why is as well. Like if they're going through rehab without any purpose, that can sometimes make it hard for you to plan their next step. So if you know what their end game is, you can then almost work backwards to find out what you need to do.
Do you have any techniques for that? Because as a coach, as an allied health professional, you are. It's like that is critical, because if it's Viktor Frankl who was a Holocaust survivor, a sufficient why can bear almost any how, right?
Yeah,
and the how
yeah.
is the excuse and the reason not to do something. So how do you find that for people? Because there's so many ways to go about it. You hear Tony Robbins talk about it. You hear like all these speakers talk about it. How do you do it?
Yeah. One of the first conversations I have with people going through ACL rehab is, what are we doing here? What are we getting you back for? What's important to you? And I think it's you try to just ask them that why. Like, I don't have necessarily a recipe of questions or a pro forma question. It's just really having a conversation about the person,
Yeah.
and what they want to do, and probably take that little bit broader approach too. Because I find that, most of my patients may be in their 20s or 30s, and life is starting to get in the road for them. Like, they might be going, that they might be, have just started work, they might be getting married, they might be having kids, they might be, just in a different life phase. And I've sort of been through that. So I can now um, empathize and sympathize with some of the struggles that they're coming along. And particularly, say, for example, a 30-year-old male or a 30-year-old female who's maybe got one or two kids with them, and they're trying to juggle work and life, yet they also want to go back to sport. It's like, I think what comes with age and experience is that you can sort of know how hard it can be for people. And so to have those, conversations with someone too, to say, look, I understand what you're going through at the moment, but we're going to get you to your why, and we're going to get you to where your goals want to take you. And I think it's coming along with the journey with them is important as well. But ultimately, you got to know, what does this person want to do with their rehab? What are we getting them for? Why is it important to them
Yeah.
to do that? And if you start to understand those reasons, that's when you can really become an effective physio and an effective coach. But also know, what are some of the barriers that that person's got to overcome to achieve that goal. Do they have a really crazy work schedule? Is their work-life balance out of order? Do they have a young family that makes it hard for them to achieve their goals sometimes? And when that happens, you've then got to just really prioritize what's important in each rehab phase. You may give them only one or two exercises to do in that session, or you might just, make those rehab sessions a little bit short, sharp, and intense, because you've only got half an hour to work with them, because that's all their window for the week is 30 minutes, or two sets of 30 minutes is all they got. So you have to be flexible as a physio or an S&C coach to work with them, not be a dictator saying, you got to come and see me 3 times a week for an hour. Some people simply don't have that. And I think that's where some people fall flat with their rehab, because their rehab is so out of out of control. They just simply can't do it. So they throw their hands up and say, "Oh, stuff it. I'm not going to do anything." And that's where I think we may lose it
That's a great
as health
point. You're trying to
professionals.
lower the barrier for entry based on the individual's own lifestyle, stress, blah blah blah.
Yes. Yeah, 100%. You have to, I think we can sometimes, grab a, cookie cutter recipe and say, okay, go off and do this. But that won't work for everyone. And I find myself more often than not giving rehab programs for a patient that's only got one or two exercises in them, because all I want them to do is get that muscle strong, or get that whole entire lower limb strong. And if they can achieve that goal for the next 2 or 3 weeks until things die down or things get less busy, then that's an important tick of the box. And then it then opens up doors in the future. But if you tell them they have to do this and they have to do that, and there's simply not enough time in their week to do that, they'll just go, no, I can't do it. I
Yeah.
can't do it, so I won't do anything.
But listen to what you just said. Like, I bet in physio school, in universities, if they heard Mick Hughes say, "Hey, I only give some of my clients 1 to 2 exercises, maybe every day, every couple of days," like, I almost think that's a bombshell for so many people, because they would think, oh, there's so much to do. We got to strengthen. We got to recreate neural connections from brain to muscle. We have motor control. We have balance proprioception. All these overwhelming things, and you overwhelm the client by your own
Yep.
expertise, almost, right?
Yep. Yeah, yeah, that's right. I think, and that's come with experience too. I would, looking back to 10 years ago, I was just having this conversation with the guys in the States. I was on a podcast for. If I could go back and talk to myself 10 years ago, I'd say, just chill out, calm down, find those priorities
Yeah.
for the person, and prioritize your rehab sessions and your exercise sessions, and give, 2 or 3 really high quality, high value exercises to a person that's going to help them get better, rather than a confusing 10-step program that's going to address all these little impairments that they've got. Look, yeah, make things realistic for the person. But that comes with experience, and that comes with life experience for yourself as a clinician, but also to, as you get through your own, I guess, professional experience, you'll sort of know where you can prioritize certain exercises, or give, certain exercises or drills, because they tick 4 or 5 boxes instead of five individual exercises that tick all the boxes. give one exercise that ticks 5 boxes. And there's probably a few things out there that people could be doing. Yeah, that's a bit more efficient.
Do you have that? Like, do you have like big? That's a general question, which is kind
Yeah,
of shit. But do you have those big bang for buck movements?
yeah, for
Mobility. What
sure.
is that for you?
Yeah, so look, for an ACL reconstruction, like I mean, there's always debate about open chain, closed chain. Look, I think for the busy ACL reconstructed athlete, if they've only got time to do 3 exercises, it's going to be a single leg knee extension because we've got to hit those quads in isolation, followed by a Bulgarian split squat because it hits a lot of it hits quads, hits glutes, gets the trunk involved,
Yeah.
gets the balance control, gets the control around the distal segment as well. You can load it up really efficiently as well. And then a single leg RDL because it's going to hit that posterior chain. And once again, it's a weight bearing exercise. It's going to hit all those important muscles as well. So like they're my 3 go-tos. And if I've got more time, I'll throw in a good heavy squat, a good heavy deadlift, and a good heavy hip thruster. There's those big rocks, if they're done consistently and progressively overloaded with time, that's a great rehab plan. It doesn't have to be too fancy with unstable surfaces and
Mm.
heaps of circus tricks that are out there that you see at the moment. Like I see so much frustrating stuff out there that if we just focus on just the big fundamental movements that will help an athlete improve themselves, but allow them to accept load really well through that affected limb, like that's going to be great. And I think, unfortunately, with a lot of ACL reconstructed athletes, as you've probably experienced and may have alluded to before, is that we chronically underload that athlete for too long. We don't give that affected side sufficient loading because we're worried about it for
Yeah.
whatever
We're
reason.
scared. We're fearful, and we
We're
don't we,
scared.
we don't want to make it worse because then
Yeah,
that's on us, right? But let's
yeah,
talk about that psychology.
yeah. So look, I think and that's been a problem for me for a large part of my career. Certainly up until now, I felt much more comfortable knowing that you can effectively and appropriately load an injured limb, be it an ankle, be it a knee, be it a hip. Especially for the knee, it will tell you if it's really shitty at you for the load that you've just tried to throw at it. It'll swell within a matter of hours after your session. Now, it's not the end of the world if you have a swelling dose. It's going to just tell you, look, you've overloaded me, you've overcooked me, calm down, reassess, give it 2 or 3 days to calm down. Let's get the swelling down off it for the next 2 or 3 days and let's try again. But let's just temper it down for the next session and see how it responds. If it does it again, we've got to temper it down again. But if it doesn't do that, I think we found our magic load there for the
Yeah.
next 2 or 3 sessions. Then we can take it up that next notch again to get you back to where you were before. So swelling's a sign that you've just overcooked it. It's not a sign that everything's all of a sudden disintegrated inside the knee and you've re-injured the graft or you've completely stirred up the knee that it's now going to be irreparable. Like it's just a sign that you've overcooked it. So I think that's often a problem that we see, and I think we're a bit fearful for that. And it's an unnecessary fear. I think we can load up that knee appropriately, and we should be doing it a little bit more, and we can actually do it a little bit earlier than what most people think.
How much earlier you think?
Well, I
It's case
think,
by case, but yeah.
yeah, for sure. Look, I think after an ACL reconstruction, like you could get some. Like I generally get my patients squatting body weight, and then with some extra load from about 4 weeks.
Mm-hmm.
Um, and then getting on to some leg presses and look deadlifting from 4 to 6 weeks, even with a reasonable amount of load, particularly if that hamstring harvest site's accepting that load really well. Like you can put some decent load on a patient as early as 4 to 6 weeks. Once again, your knee will tell you if it's not happy with that load. I go reasonably cautious with the repetitions. We're dealing with 10s to 15s, sometimes up to 20s, like in that first the first 4 to 6 weeks if we're putting some load behind it. But once the knee has proven that it's tolerating that lower weight, higher rep range, that's when we can start getting into your 6 to 10s over a period of time, and then eventually into your 5x5s or your 5x3s, and whatever you want to do after that. But that load should be introduced reasonably early if it can be tolerated. If that knee can bend to 90 degrees and they can stand up from a chair, then they can squat, and they should be able to squat.
Yeah. And I think to take it back, there's a couple of things floating through my mind, but one of them is your key indicator exercises for rehab were all unilateral, which is really interesting to hear. You got the knee
Yeah,
extension, split squat, and the single leg RDL.
yeah,
And that dynamically corresponds to life, sport.
yeah,
And I just wanted to make a note of that because I think we're very quick to always love and fall in love with the bilateral movements with a
mm,
clear disconnect with the single leg movements, which are so important for proprioception, balance. Stability is huge.
yeah.
Please, if you got anything you want to say
Yeah,
on that.
yeah. Look, I think there's certainly value in like a good heavy load squat, double leg deadlift, like
Agreed.
and double leg snatch. You got some value there. But if you're only programming that, and we see notoriously with an ACL patient, they'll shift that load to the unaffected side. And they've seen that. We've seen that in a couple of studies where even a body weight squat in an ACL reconstructed patient, they'll shift that load to the unaffected side at about the 3 month mark, and then at 5 months with a body weight squat, they'll still shift the load, but they'll shift the load on that ACL side up to the hip, so they won't be bending that knee. They won't be bending that knee really well. So if we just chug along with double leg press, double leg squats, double leg deadlifts, double leg hip thrusters for too long, we're going to be chronically underloading that affected side. So there certainly is some wriggle room and some need to get into some unilateral training. When that is, it'll be up to the patient to prove themselves to do that. How much load you put them on, it'll be up to the patient, up to the harvest site, up to how the knee is responding. But if you chronically underload them, we're not going to be setting our patients up for a great overall recovery, or it's going to take us forever to try and make up for that lost time of underloading in those first 3 months. So, look, I think there's certainly some wriggle room there from about 6 weeks onwards to start loading onto that one leg, be it a lunge, be it assisted single leg squat up and down. So one simple way I do to progress a squat to try to get them into a Bulgarian or a single leg sit to stand from a chair is stand on their affected leg. Now use the other side as much as they need to help them lower down eccentrically, and then allow that other leg to help them up as much as they need to too. You may shift the load back to maybe 50 to 60% on that affected side, and you might have 40 to 50% through their unaffected side, but there's still some load going through that ACL
Exactly.
side, and then you can just naturally progress that over time. So there's some simple strategies out there. We just need to know how to adapt the rehab plan to suit the athlete in front of us.
And it's also it's a note on being unemotional about pain, right?
Yeah,
I think,
yeah,
and I'm been guilty for this out of ignorance. Didn't know.
mm,
Then I learned from guys like you, guys from like Jordan Radcliffe, a great up and
mm,
coming coach at Woodford's.
mm,
They're teaching me that okay, pain is just a feedback mechanism, and we look at the post 24 hours, 48 hours to see the
yep,
window of tolerance.
yes, for
Can
sure.
you break down like the psychological, emotional aspect of pain?
Yeah, look, I think that's often a thing that I communicate with on the patients is that, look, we have to take you through a bit of tough love here. If we're going to have a good result, if you want to do great things with your knee in the future and you want to get back playing sport, we've got to be a bit tough with you from time to time. If we go through rehab and you don't experience any discomfort or pain, then we probably haven't loaded you enough. So my rule of thumb
You
with
just said you haven't loaded them enough if they're not pushing the boundaries and feeling a little bit of pain. I just
yeah,
want to clarify.
yeah.
Awesome.
So
Keep
if
going.
yeah, so we need to load you. We need to take you to some uncomfortable positions. If we go through rehab and you have 0 out of 10 all the time, then we're not doing our job properly. Like there's a threshold. There's 0 out of 10. I use a simple 0 to 10 rule. So 0 is no pain. 10 out of 10 is the worst ever pain you've ever experienced. A 3 to 4 out of 10 out of 3 to 4 out of 10 pain scale is kind of my threshold for tough love.
Got it.
If we take you beyond a 5 or a 6, we're probably going to flare you up, and we're going to do so, and your knee's going to be crappy at you for the next 3 days. It's going to be uncomfortable. It's probably not worth what we've just put you through. But to have a little bit of discomfort in your knee, around the knee, within that session, that's 2 or 3 out of 10. And if then for the next 24 hours, you still got this little grumble around your knee for 2 to 3 out of 10 for the next 24 hours, that's great. That's what we need to do to help toughen you up, to make you a more robust, resilient athlete, but also a robust knee that's able to then progressively be overloaded with time. Because what hurts today and tomorrow, you do that same session in a week's time, it's not going to hurt so much. But if we overcook you and take you to a 5 or a 6, we're going to be riding this boom bust cycle where you get flogged, and then now you're out of action for the next 2 or 3 days because he's got this really irritable knee. So if we don't listen to your pain, we can do harm. But we need to listen to your pain and take you to a level of just discomfort, but not significant pain that's going to swell. And I find that 3 to 4 out of 10 scale is a pretty good rule of thumb for most people going through ACL rehab. So, to experience 0 out of 10 pain through your rehab is potentially probably undercooking your rehab and not giving you the best outcome either.
That's super practical. Like, thanks for mentioning that too. And we got some comments from Facebook, some more humorous comments. Lockie Wilmot from Athletes Authority would love to know his favorite brand of chinos. Also, RM Williams in a clinic setting. Great discussion topic.
Well, my favourite pair of chinos, I've got some, what have I got on today? I don't know, some, I can't even see, but they're good. They're good, and they're tightly fitting, Lockie, for you. They hug my calves really well. I've known to have, disproportionately bigger calves to the rest of my legs, so they fit snugly. RM Williams, I'm actually off them a little bit. They're a bit expensive for my taste because I chew through my shoes pretty quickly. I probably should upgrade though, but YD shoes, mate.
There you go, Lockie.
Non-slip surface.
You take that. And Kennedy Lay. Go ahead.
I must say, Lockie has made me think differently about my clothing attire. He's been a great proponent of me to get me thinking differently about the rehab choices of clothes. He's made me think deeply. And thank you, Lockie, for that. I appreciate your kind words and feedback all through my all through the years.
He's just looking out for you,
in
different ways.
He is.
And Kennedy Lay, I didn't notice this. Is that red wine, Mick?
Red wine? Whereabouts?
Well, you tell me.
Here. No, this is delicious long black coffee.
All right, there you go. It's a bit too early for that, I think.
Bit too early.
But to go back early in our conversation, I wanted to ask you about, we talked about swelling and inflammation, and that, swelling is a kind of byproduct of inflammation, and it's deemed as the enemy. And I'm learning this from a guy called Gary Renal. I can't remember if I'm saying that right. And basically talking about how swelling is like a byproduct of the inflammation process, and one of the best ways to move it out is through the lymphatic system, is through movement, through things like muscle stimulation if you can't move very much. Do you use that stuff much?
I don't use a lot of technology, to be honest, but I certainly encourage the removal of swelling through active muscle contractions. And perfect example of this, once again, early ACL reconstruction or even ACL injury, when the person sustained an acute knee injury and the knee is swollen up like a balloon and it's quite stiff and sore, and even like an ankle, the best thing to help remove swelling, in most cases, is active movement as tolerated. So for a knee that's been recently injured or reconstructed, I'll be asking that person to be flexing and extending that knee, trying to get a good quad pump to help flush out that fluid from around the knee and dissipate it. Good ankle pumps as well to get that calf, basically pumping and squeezing some of that debris that's sort of hanging around the ankle joint. And obviously combining the two actions, you're going to see some nice return and removal of some of that fluid that's sitting around the joint. So one of the more powerful ways to get things moving proactively is through active muscle contraction. So get them moving, get them pumping, get them, doesn't have to be heavily loaded acutely after an injury, but one way to get rid of a new fresh dose of swelling is get those muscles pumping. And once again, I like the exercise bike for that acute injury phase, very little load going through the knee, but man, it helps that knee pump and squeeze. It helps that knee bend and move. It helps the ankle maintain some degree of flexibility there. There's so many positive things to achieve in the acute setting rather than just letting the person rest and recover and put them in a brace unnecessarily, or restrict their range unnecessarily when they don't need to, or just, put them on crutches once again unnecessarily for too long. Like, there's a time and a place for all those things. But if we have them for too long, then it's only going to be at a detriment to that person, and it's going to, delay their recovery. And in terms of technology, I don't use much at all. I don't use much of, Compex or Stim, eStim, or that kind of stuff. I want people actively doing it themselves where possible, rather than letting a machine do that stuff for them.
Right, that's fair enough. And I would, in kind of to add on to that, I would suggest that if someone even has an immobilized limb, fully immobilized, they can't move it. I've found, and I'm finding with some of my clients and athletes, that muscle stim up and down the site is actually pretty helpful. And even there's some good research out there that shows that you can massively mitigate atrophy, muscle atrophy. If you're bedridden, for example, and you muscle stim that muscle site, so much atrophy is minimized.
Yeah, and there's certainly a good body of evidence in the ACL world where you use electrical stim in the first 4 weeks, 4 to 6 weeks of rehab after an ACL injury, when you can't really utilize your quad as best as possible. You can't use your hamstring as best as possible. There's certainly good research out there that says that you can. I think in my clinical setting, it's because I actually don't see a lot of post-op patients in those first 4 weeks. They tend to come to me later on in the piece. So I see a vast majority of my patients are later on in the piece where
so you could get moving immediately.
I would, yeah. The ones that I do see, I'm utilizing active means as much as possible to try and basically minimize that wasting, so that they don't have to reach out so much to the electricals and the passive modalities where possible. Like, I think isometric contractions early are often underutilized and not done enough. And I think just basic range of movement stuff can be really helpful too, rather than put someone in a splint or say, let's go non-weight bearing for too long. Like, we can get that person moving really well on their own terms. Obviously, there'll be some post-op restrictions that the surgeon will put in place, but that's where isometric contractions can be really, really powerful. And I think we need to be sort of maybe working with those a bit more than what we currently do. But yeah, e-stim, electrical stims, they certainly have a role to play in the certain athletes and certain post-op
But I think the answer
recovers.
is probably somewhere in the middle. It's like you don't want to just do one or the other,
Yeah,
combining
that's right.
multiple
Look,
interventions.
100%. If you're sitting down and just letting that work doing its thing, and you aren't actively trying to engage in it, I think that's where we may run into problem every now and again. Like, use the technology we've got, use the stimulation that we've got, but also try to have a go yourself. Try to actually contract that muscle yourself to have a bit more powerful effect.
Great point. And I think I saw you make a post about protocols for around icing and alternatives. I don't know your exact thoughts on it,
Right.
but the rice protocol that Dr. Gabe Merkin created, he's actually in his 80s gone back against that and talked about how now we know that ice actually delays healing and recovering. Maybe you have different thoughts, but what are your thoughts on icing and its efficacy and how it can actually be maybe even detrimental?
Yeah, look, I'm just sort of guided by what the research is showing, and as you said, like, it certainly can delay the recovery. And I still use ice more so from the analgesic effect, because it does still have some utility there. And I'd certainly be encouraging, if you've got an acute injury, if you're in pain, sure, use it to your advantage. But I think there's certainly an overdosing and an overuse of ice where we certainly should be getting the person moving a little bit more, and maybe second guessing how much we use. But I mean, it's such an ingrained culture within the medical fraternity and S&C fraternity, where someone injured themselves, chuck a bag of ice or get them into an ice bath or something like that for a sprained ankle. Now, look, there's probably a role to play, but more so from the pain relief perspective. But I think from a tissue modelling perspective, the research is showing that there's a potential that it actually can delay some of our healing potential there. And I mean, case in point, like, I know one athlete case studies are not the best. I wouldn't call myself an athlete, but my recent ankle sprain that I had was a pretty nasty grade 3 lateral ankle sprain. I iced my ankle for about 10 minutes acutely afterwards because it was bloody sore.
Yeah.
And I didn't put a bag of ice or put it into a bucket of cold water for the next, up until now, 8 weeks later. But I noticed, like within 24 hours, I was moving okay. I was walking without a limp. I was a bit stiff. I was a bit sore. I just got loading on it, and you know, I think if you saw any of the videos, I was hopping, jumping, and landing, and doing some really active things reasonably well. And I think we probably once again we don't load up enough. And we don't sensibly load up enough early. I think sometimes with simple injuries like an ankle sprain, for example, we may go partial weight bearing for too long. We might put them in moon boots for too long. We might say, let's ice it, 24 hours around the clock, all too long. And is that to the potential detriment for the athlete? I guess it's hard to say because you can't really put I haven't seen a study where they've gone head to head with different icing protocols or anything like that, and it can be hard sometimes to do that. But in theory, if we are seeing a potential harm in tissue regeneration and delays in tissue regeneration, then it's got to make us question as to do we keep icing for too long? And I think that's
100%.
probably you just need to think about why are you icing this athlete? Is it for pain? Fine, but is it for swelling reduction or to help range or for other things? And you've got to be thinking, is there another way to get this happening? Yeah, if we're trying to do swelling reduction, let's get them moving. Let's get them loading.
Yeah.
Let's do things in other ways more proactively rather than just dumping a bag of ice on it.
And that's what I've read and heard is that applying that cold and that ice can actually trap more fluid there because there's no movement. You're getting vasoconstriction. You're not getting that really good inflammatory response where macrophages, white blood cells can storm the area and clear the area. And then
Yep.
your answer is movement. Move the
Yep.
lymphatic system so we can move the fluid in a more natural way instead of trapping it there with ice.
Yep.
That's the things that I've been learning. Anyway.
Yeah. Yep. No, I agree. I think we just need to have a deeper thinking, a bit deeper understanding of what we're doing and why. And I think certainly that recent article and that review by Escala and the other author, but it was in the one I shared on Peace and Love from the British Journal of Sports Medicine blog post. It's a really good it's a good read. Anyone to have a read of it. It's on there. I think the article itself, the review article, I think it's behind a paywall, but the blog that the authors wrote, it's a free blog for people to read. So if you type into your web browser BJSM Peace and Love, you'll have the blog summary there that really challenges our current icing belief. So give it a read.
People might think like, what the hell are you talking about? Peace and love. Protect, elevate, avoid anti-inflammatory, and then load, optimize, vascularization, exercise. I don't remember that. I have it in front of me. Sorry.
Yeah.
Don't worry. I'm not that
I'm
good.
glad you didn't ask me because I wouldn't have been able to remember. But it's a nice acronym.
Yeah, well, it just gives us an alternative method application to dealing with inflammation, musculoskeletal injuries. And
Yes. Yeah.
I want to shift gears to the personal trainer. Orphic
Yep.
Education. We teach and regulate certificate 3s and 4s in fitness. And I think there's often a gap between personal trainers and physiotherapists. What can the personal trainer learn and take from the physiotherapy world that you think they're missing, and the coach and that you think they're missing that they could learn and take?
It's a good question.
Where are we getting it wrong? Where can we be better?
Yeah, look, I think everyone's got their I think everyone's got their limitations to their career. And look, I mean, physiotherapy, it's a 4-year degree. It's hard to compare a 4-year degree where you're learning a lot about the pathophysiology. I think that's probably the thing is the pathophysiology injury. It is really important to understand, and to know that some tissues certain times in their recovery stages, like ligaments respond differently to muscles to differently to tendons, and bones and cartilage respond differently to all four. And so not all injuries are going to be created equal, and not all rehab plans are going to be created equal. I think that's where I think maybe some personal trainers run into a bit of strife with their patients or their clients, in that they may um, put all their clientele under the same umbrella, where we need to be a bit more flexible in our thinking. If you have a muscle strain, for example, that you're rehabilitating, you can be a bit more aggressively with that compared to a chronic tendon that needs some more care and more rest in between sessions of high intensity sessions too. Whereas a muscle can probably be pushed a little bit harder, can be strengthened a bit harder, but tendons have to be treated a bit differently. Same thing with bones and cartilage as well. So I think importantly, regardless of our limitations, we all need to work together. And I think that's where communication really needs to come together as well. So if you've got a, a client that you're working with who is injured, it's important that if you're a personal trainer, you're reaching out to therapists to say, hey, look, what can this person do? And importantly, the onus is on the physiotherapist to reach out to the personal trainer as well. This person's got this type of injury, and they probably need to be a bit careful with this type of exercise, or don't do too much of this work, because of reactive tendon, they won't be able to handle four sessions of plyometrics. They might be only able to handle one or two. So the onus is on the physiotherapist about what the person could do that week. So yeah, look, I think there's each person just needs to communicate it. But I think, yeah, there's a big, there's a lot to learn in terms of, I guess, that the pathophysiology behind something that needs to be discussed and shared between both the physiotherapist and the personal trainer to help the client move forward. That answers your question. I think I might have got a bit off track with that
No,
one.
that's what we're here for. We're here to go all over the place. But I think, from my interpretation, it's part of that answer seems to be coming to the physio and communicating really thoroughly to understand.
Yeah.
When you're referring in and out, understanding their particular recommendations, but then also at the same time putting the onus on the trainer to have their own education as well, of understanding different repair, remodeling, and interventions with different types of tissue damage and injuries, like tendon, ligament, muscle. You said, what is the best, most succinct way to learn those pillars
Yeah.
without doing a degree, for example?
Yeah. Well, I think it certainly does need some advanced learning there, but I think as a general rule of thumb, ligaments and muscles have got great blood supplies, as do bone. Most bones. Some bones don't have the best blood supply, but generally speaking, bones have got a pretty good blood supply. Ligaments have got a blood supply. Muscles have got a good blood supply. So those tissues there are going to heal reasonably well, and in a reasonable short period of time. So somewhere between 6 weeks on average. It's going to turn over new cells to make us have new tissue in that area. What helps that tissue respond though is load. Your body's got a great ability to grow and adapt if we impose load on it. Those tissues there have got great blood supplies and have got a great ability to become stronger and more resilient and tougher. Tendons, on the other hand, have got a crappy blood supply. So they're the ones. So an Achilles tendon, patella tendon, lateral hips, elbow tendons, shoulder tendons. They're a really crappy blood supply that makes it harder for them to heal. So, from a time perspective, when we're dealing with someone with a tendon pathology, they're a little bit trickier, and they're actually can be really difficult to treat in some cases, particularly if someone's unwilling to rest, or if their training plan is all over the shop and they don't have a plan, or they're being brutally trained week in, week out. And that tendon just doesn't get a chance to remodel and toughen up over time. So for I guess general rule of thumb there, an expectation if someone's got a tendon injury is it might take a good 12 weeks at least for them to overcome that problem and get on the front foot with it to become a much more manageable condition. So that would be a very simple way to look at things. Things that have got a good blood supply, ligaments, muscles, and bones, they heal really well. Tendons, crappy blood supply, don't heal well. Cartilage, no blood supply, doesn't heal well. So yeah, that would be my sort of line of thinking when we're sort of dealing with different injuries.
No, well, that's great. That's well said. You summarized it, I think, however many hundreds of hours of education that took to come to, or maybe you didn't.
Yeah.
Um, you just summarized it really well. I wanted to ask, actually, I don't want to forget, um, do you ever use heat in your recovery practices with
Mm,
musculoskeletal injuries? Because, with the heat stress and sauna use never being bigger, and all these amazing studies from Finland and these Nordic countries coming out, and it having such big benefit in reducing
mm,
systemic inflammation through heat shock proteins and vasodilation,
mm.
blood flow, capillarization. Do you think there could be something there to the application of heat early, middle stage?
Yeah, yeah, maybe. Certainly, um, certainly with people with chronic pain, I'd be sort of, I'd tend to advocate for a little bit more if they respond really well to heat and helps dull down their pain response and allows them to train and move and exercise. I'll certainly use heat more to advantage. I think from a recovery process, it's probably something I haven't um, worked enough with it from the athletic point of view. I know with the athletes I've worked in the past, we was kind of standard practice. Once training session's done, chuck them in the 10-degree bath for 10 minutes, and or if they wanted to contrast in between cold and
Yeah,
hot for the 10 minutes after the session. After games, once again, after the games, we chuck them in the cold bath for however long they wanted, or that contrast in and out. But I think from a purely heat perspective, yeah, it's something I haven't really tapped into before. But if there's some evidence out there to show that it's got some potential benefit, yeah, I think it's worth exploring a little bit more.
I think the
Um, yeah, I think the only other, probably people would probably get nervous about is that heat in that really acute stage where you're basically going to encourage a whole lot of extra blood flow and swelling to that affected area soon after the injury. Like that would probably be the only other thing. But once again, what comes with blood is some healthy tissue healing potential and growth factors and all these other helpful cells to come along and help the recovery. But um, I don't know. It'd be something we need to see a bit more of and read a bit more of in the future.
For sure. No, I just wanted to get your 2 cents on that because it is emerging. But on the topic we were talking about before, ACLs, this gets talked about so often, and you deal with so many. And then what's coming out now, and that's emerging in these last 5 years, especially, is that hold on, we don't actually need the ACL to
Mm,
function and live. And
mm,
this is
mm.
such a dogma that
Yeah,
people have been opposed to. You got to have the surgery. Surgeons got to
yeah,
make their money, and physio's gonna be involved anyway. But
yeah,
challenging this perspective on the worldwide basis is huge because there's so many people who still think you need the ACL, absolutely need
yeah.
to get surgery. Can you talk about? I want to break this down
Mm, mm,
so the whole world can hear
mm,
how a human being can function without their ACL and even other cruciate ligaments. How do you know
mm.
if they're COPA, non-COPA?
Yeah, look, it is, and unfortunately, there is that dogma that if you injure your ACL, regardless of what kind of activity you're going back to, you need your ACL to function, and it's not right. It could be further from the truth. Like I think once again, if I go back 10 years to my early years as an ace, working as a young physio, I remember probably hearing an orthopedic surgeon or two saying, "Look, if you're over the age of 40, you don't reconstruct. If you're under the age of 40, you do reconstruct." And it was kind of like how it was. But now, certainly the research is emerging and things are being challenged a lot about ACL injury management. And I think the important thing to know here is that patients have a choice. Unfortunately, they're not given that choice though. Here in Australia, our reconstruction rates are probably up around 90 to 95% of all ACL injuries are offered reconstruction. In Scandinavia, the reconstruction rate is as low as 50%.
Well,
So, they barely reconstruct. And basically, they reconstruct on patients who prove themselves to be unstable.
yeah,
Now, I think here in Australia and many countries around the world, we don't give the person the opportunity to prove themselves to be unstable. we don't give them enough time to prove that they actually can be a coper, and we don't give them enough time to prove that they can actually help themselves on rehabilitation alone. They're often injured the ACL within a matter of weeks. They're having a reconstruction, and I don't think that it certainly isn't best practice. Now, it's going to take a long time to change that mindset, but the person can absolutely live and function and live a normal, healthy life without an ACL. Now, the question remains is, can they return back to their pre-injury levels of sport
That's
without
yeah,
their ACL?
exactly.
And that's a very, very difficult question to answer, because some people can, some people can't. The people that can, the question then further remains is, will they have another instability episode that further worsens their knee? Do they go on to sustain a meniscus injury or a cartilage injury? Then which then makes their knee really crappy in years to come. We that's a real risk. Um, but in saying that, those that have had a reconstruction that doesn't guarantee that knee survival. It doesn't guarantee the meniscus survival or cartilage survival in the future either, because we know graft injuries are quite common as well. And second ACL injuries are very, very common on the other side as well within a matter of years. So surgery isn't 100% successful either. So I think ultimately the knee can function without the ACL. We just need to allow that person to prove themselves. Now, there is a classification system out there that we should be encouraging people initially to go through, and it's to determine if they can be a potential coper. Now, a potential coper is someone who has the potential to cope and live their life and return back to some sport one way or another without their ACL. Now, that's generally done. If you look at the research, that test and that algorithm is really usually put place around about 4 weeks or 6 weeks post injury, when their knee is really settled. So they got full range of movement, they got their quad strength back, and they got very minimal swelling. Now, that COPA classification is 2 questionnaires. It's asking the person if they've had an instability episode or not since their ACL injury. And it's a 6 meter timed hop test, and making sure they're within 20% of their other side. Now, if they tick all those 4 boxes, they're a potential coper, and they're then encouraged into rehabilitation. Now, someone that fails on that algorithm and just fails on one of those things doesn't necessarily draw a line through them to say they can't go on to cope, because we know that those that initially identified as a non-coper can actually change their coping status with high quality rehab. And we can turn the corner with them in as little as 6 weeks. We can turn them from a non-coper into a potential coper with 6 weeks of rehab. So in up to 50% of cases, we can do that as well. In some
Really?
cases, some cases just may need more time. They might need 3 months of rehabilitation to turn the corner from a potential non-coper into a potential coper. So I think that's the thing. Often people aren't offered high quality rehab after their ACL injury to prove if they can be a potential coper, or in those that are actually even lucky enough, start to feel stable and clinically stable to prove they actually could start trying to train and play again. So look, there's just so much misinformation out there, and I think unfortunately a lot of people do get reconstructed too early, and they aren't given a choice, and they don't get the opportunity to prove themselves to be a potential coper, or prove themselves to have a crack at non-operative rehab for a longer time than what they should. Now, it's just a hard decision to make for someone who's really athletic, that wants to play sport, and wants to jump and land and pivot and play sport, like that, and especially a professional athlete. It's very, very difficult conversation to have, because there's a lot of extra pressures put on that athlete. Like if you went to an AFL club and someone tore their ACL, could almost guarantee they'll be having a reconstruction 2 days later, if not a day later, because they're, it's so grey in that return to sport. They could roll the dice. They could rehabilitate their knee really well. They could be back playing sport within 9 weeks, like that elite level Premier League football player we've seen a case study of time and time again that we talk about. They could play an extra 2 or 3 years without an ACL and have a great career. Conversely, they could also come back to sport within 9 weeks, have a re-injury, and a worse knee re-injury at that. And then that's now 9 weeks behind schedule. Now, in a professional club environment, you won't keep your job very long if you've just now wasted 9 weeks with an athlete because you've tried to roll the dice, or they've tried to roll the dice. So it's a very difficult decision to try and help an athlete, a professional athlete, work through. And more often than not, the default button will be, let's reconstruct and let's get that person back in a more black and white time frame. But for the other 99% of us who aren't working with elite athletes or aren't elite athletes, we should be given more of a choice when it comes to ACL injury management for sure.
Beautifully said. I think that's so important what you just said, Mick, because what we and that idea is fighting against is, I'll give you an example. You have people who aren't as informed on the rehab. For example, I mentioned it before, Joe Rogan on his podcast goes out to millions and millions of people. He emphatically talked about, he's had surgeries like that. He emphatically talked about, if you do your ACL or something like that, just get the surgery done. And he harped on that point many times. And like, this is the idea we're fighting against, of someone that influential with that big of an audience, which just makes that battle to climb up that hill so much harder. So how do you think that this idea on the other side gets traction?
Yeah, it's hard. Like, I mean, I've been consulting with this lady based in Toronto just recently. So she had an ACL injury back in January, and so before COVID, she'd met with I think 3 surgeons and met with a couple of physios, all of whom said, you need an ACL reconstruction. Now she's late 20s. All she wants to do is, dance and run and go to the gym and do all these kind of things. And I said, when I had a consult with her because she couldn't see her physio, she couldn't, do anything, go to the gym, for example. I said, look, the activities that you want to do lend themselves to, absolutely should be offered a non-operative rehab here. But unfortunately, there's just this ingrained culture that, an ACL injury is associated with a reconstruction. And that's going to take a long time to shift. That mindset's going to be very, very long. And it doesn't help, like when we've got professional athletes, tear their ACL, they're having reconstruction the next day or two. You got people with big audiences like Joe Rogan, as you mentioned, who, really advocate for ACL reconstructions. Like it's hard to try and get people to think that non-operative rehab is an option. And it absolutely is. And it should be something we encourage, if at the very least, if we can rehabilitate that patient's knee soon after their ACL injury for at least 3 months, even if they choose to have a reconstruction, it's time not wasted, because it's effectively really good pre-operative rehab that's only going to better them many years down the track. And we've seen that many times over in research studies on pre-operative rehab, that if you go into that operation with a really strong and highly functioning knee, your quality of life and your function and your ability to return back to your pre-injury levels of sport are so much better than those that just have their ACL injury and then go into surgery a week later or a few weeks later. So rehab really matters. And if we can get that person for 3 months and talk to them about options and talk to them about extending their rehab pathway longer, then that's a pretty big win.
Is that your threshold? 3 months to see if they're officially COPA or non-COPA?
Generally 6 weeks minimum, but I'd love to have 3 months with every person that I've had and every person that I rehabilitate acutely. I really advocate for at least 3 months, because in 3 months you can get that person really strong and confident, and you can also start weaving in jumping and landing and running to really boost their confidence even more, to get them to say, hey, look, I actually don't feel too differently now. And look, if they still want to have a reconstruction and they're still fixated on that, fine. But if they get to 3 months and they can jump and land and hop, and you can show them that they actually can do these things without their ACL, then that's very, very powerful to the person, and hopefully allows their confidence to grow. And then if you can extend that out even longer, that's great. That's really, really great.
And I want you to, if you don't mind, talking about a recent post you made about ACL can repair, right?
Yep.
And you showed these really great graphical images of this MRI. And after 4 months, I'm actually going to put it on the screen for everybody. After 4 months, you had this all the tissue really nicely bundling up together. Can you talk about that case study?
Yeah, for sure. Like, he's the fella in question, I won't name names or give anything specific, but he was a young man who injured his ACL. He actually had another injury on his other side previously, about 2 years ago. So he had a reconstruction on his other leg 2 years ago, and then he was playing footy, and tore his ACL on his other knee, which you see from the images there was his 2-day post-injury MRI images. And so he also had an MCL sprain as well. And so he saw the doctor, and the doctor put him in a splint for 2 weeks, and then said go see physio after 2 weeks and get it moving. And so I caught up with him for the first time at 2 weeks, and so we got it rehabilitating. One of the first things he said to me, he goes, I've come to see you because I know you're an advocate for non-operative rehab, and I don't want to have another reconstruction. So I said, all right, let's get you moving, let's get you rehabilitating, let's get you strong. And so we just got him moving, we got him strong, we got him into a rehabilitation plan that involved all the good big rocks of squats and deadlifts and all the things that you should be doing, knee extensions, hemi curls, calf raises, loading up appropriately. And then when I caught up with him at about the 3.5 month mark, 4 month mark, I tested his knee again clinically because he was looking really good. He'd returned back to work and was looking really good. And I tested his knee and I said, feels quite stable here. It actually feels as, the test that we do to determine if someone's got an ACL injury or not, it's called a Lockman test. So his Lockman test felt the same as what it felt like on his other side. So his reconstructed knee was strong and stable, had an abrupt endpoint and a hard endpoint. And so had his recently injured side. His 4 month now post ACL injury knee had started to become clinically stable. So I was like, man, I think something's happening here. And he was in a position where, I mean, we routinely don't re-MRI things just to check and see, but he was really keen to explore that option to see if he was one of these, lucky people who could heal. And we got his MRI back and it showed realigning of his fibers. Now, that ligament still got a bit at that time point, 4 months, it's still got some healing to do, but the alignment of the fibers had started to look like how it should. Like, yes, it needs to become blacker and look a little bit differently over time. But that'll happen. If we keep loading it, that body will continue to remodel new tissue over time. And hopefully by the end of 12 months, if we were to re-MRI the knee at 12 months, it'll look like a nice black line there instead of the whiteness that you see in it. But I think there's this, once again, so that was his case study, and he's now back playing basketball. He's thinking about playing footy again. He's not 100% sure about footy, but he's back engaged in all his life. His quality of life is great. He's playing basketball again. He's engaged with his mates and, back to training and living a normal life again. And he's dodged a massive bullet. And I think, unfortunately, once again, we can't guarantee that people can heal, but it does happen a lot more frequently than probably what we're led to believe. Now, when I was at, once again, physio school, I was quoted at 1% of all ACL injuries can heal. I think that number may be a bit higher than that. We just don't give people the opportunity to prove themselves to be these lucky ones. I don't know what the percentage of people that can heal are. I know there are some case studies out there, and there's some studies out there that show healing in certain populations. These aren't prospective randomized controlled trials, but they're nice case series of people who show signs of healing. So it does happen. We just need people, once again, if people are going to heal, it's going to happen somewhere between months 3 and month 6, and we'll see that visually on an MRI, and clinically we'll start to pick that up from about month 3 onwards. And that's where I think if we allow people to rehabilitate for at least 3 months, and then they can prove themselves to first be able to be a coper, and then secondly, maybe become clinically stable, that's a huge win for everyone, because it's we've potentially dodged surgery here and another trauma to the knee. And that's one thing we often forget, is the ACL reconstruction is often traumatic for the knee, very traumatic for the knee. You've got to drill through the knee capsule, you've got to drill through bones, you've got to take new harvest tissue from the hamstring or patella tendon or the quad tendon, which is a new insult to the body. You get new reactions, new inflammations. It's another trauma the knee's got to go through on top of the ACL injury it's just previously gone through itself. So if we can limit the trauma to the knee, that knee is going to be a hell of a lot happier for you in 10, 15, 20 years' time. So yeah, that's kind of, I think, hopefully that sheds a bit of light.
Absolutely, and I put the images up so people could see, and it really, I think it makes tearing your ACL a lot less scary, because surgery is pretty intimidating for a lot of people, especially if they've never done it. Like you said, there's multiple trauma sites, you're going through bone. Well, now we have this amazing option where you don't have to get it. You can try and see. And I
Yep.
think, in my perspective, and it sounds like your perspective, that should be the first option, because this is not just an idiosyncratic, like, individual decision. It's systemic in the fact that it affects a medical system, and it takes a little bit of burden off a medical
Yep.
system, which is
Yes.
benefits both parties.
Yep, that's right. And I think that's a really important message that, yeah, it's less burden, potentially less burden to the greater healthcare system. You know, if we're not reconstructing every ACL that walks through the door. Now, like it must be said that not all ACL injuries can be offered a non-operative pathway, because there are some other injuries that are sustained at the time that do lend themselves to needing a reconstruction. Like if you have an ACL injury and you've got also a pretty big meniscus tear that's able to be salvaged, or if you've got a cartilage injury there that can be repaired, those things really take precedence over the ACL injury, because it's the meniscus injury and the cartilage injury is the thing that's going to develop knee osteoarthritis in years to come. Not necessarily the ACL. The ACL just provides stability. It stops the tibia drawing forward. It stops the external rotation. So, you know, in theory, the ACL, without an ACL, you get extra movement there, which then can add to shear. But that muscular system from the quads and the hamstrings and the proprioceptive input and the glutes, all these things can make up for that loss of ligament tissue if it doesn't restore again. But, you know, like if we can limit the trauma and allow the muscles to really get that rehab up to a high quality to provide that knee better stability, then that's a win. But unfortunately for some people, there's going to be ongoing instability there. And if there's been some instability there that's, you know, tearing the meniscus or making that cartilage worse, and then that can be a problem. Now, case in point, once again, recently I had a non-operative guy. It's not all rainbows and sunshine with our ACL reconstructed or ACL injured patients. I had a case where I had a guy who was going non-operative. He was about 4 months post-injury. He was doing some jumping and landing stuff at home, and he had a trip and a stumble, and his knee buckled, and he tore his meniscus. And so he had a meniscus repair just recently. So it's one of these things that not all things play out well.
That's very
So
honest of you to say, because from the sounds of it, he was doing something you prescribed, like an exercise program, very basically, and he got injured from it. And I have a lot of respect for you, Mick, for mentioning that, because that's a vulnerable position as a physiotherapist and coach. It's like not everything we do is going to work. Sometimes
no, that's right.
it fucks up.
That's right. And he, you know, like he ticked all the boxes along the way, and he'd been strong, he'd been stable, he'd proved himself at other exercises along the way. And unfortunately, and this isn't the first time. Like, I mean, I've had other people return back to training and sport going non-operative who have had little instability episodes, who've dodged a bullet. They were lucky that they didn't worsen the knee the next time around. So they got quite lucky. But for this young fella here, he unfortunately, when he had his little instability episode the next time around, he did tear his meniscus. And so so he had a meniscus repair done. So these things happen along the way, but everyone needs to know what the risks and the benefits and the harms are, and potentially, if everyone's, you know, on board with that, then let's go. Let's rehabilitate and let's get things moving.
Is that why you can stay a bit emotionally detached from it, because you've talked about all of the pros and cons? Like, this may happen. For example, I'm trying to allude to the fact that, you know, sometimes as health professionals, we could feel, I mean, at least me, I feel guilty. Like, it's my responsibility. If, like, my client or athlete fucks up, like, I put that on me. Like, if I'm going to take their success, I'm going to take their failures. And maybe that's not always the best way to think about it, but how do you detach any ill feeling or guilt? Like, man, maybe I should have done that differently. I feel like you feel bad about yourself.
It's hard, and I probably had that experience a couple of years ago too. Like with when I worked with netball, we had an ACL reconstructed athlete at netball, and she had a second ACL injury to her other side when I was there as part of the club, and I took that to heart. I was I was going through all her programs and all her tests and all that kind of stuff, because I just couldn't sleep well at night, just knowing that I thought of maybe I'd contributed to her second ACL injury, and I'd go through all the data, and I was just like, man, I was pretty gutted by that. And that was probably a key learning moment for me, because going through all that, it made me sort of realize, look, I sometimes you can't avoid injury. Sometimes you can't. As long as you're doing everything to the best of your ability and you are keeping your own, you're doing things as best practice as much as possible, and you're not going rogue and you're not being completely cowboy. Um, if you're doing things each and every day that make you sleep well at night, then you can, sometimes bad luck happens, and sometimes shit happens to the best of us. But as long as you are doing your best job each and every day for your athletes, and you can go to sleep well at night knowing that, then you're doing a wonderful job. And I think if you go, and this has been, like I said, this is a learning experience for me, is that, if a second ACL injury happens, I don't probably go trawling through my data again trying to figure out, was there a reason why. Sometimes these things unfortunately just happen, regardless of what your input is. But as long as you're doing your best each and every session for that athlete, then you can always, hold your head up high and say, I've tried my best, I've done my best. And unfortunately, this was just one of those unlucky things.
You trust your process now, huh?
Yeah, exactly. Yep, yeah, exactly. And look, I was devastated for the young fella just before
You
who
would,
did
because you
the injury
care,
his knee.
right? You care. We,
Yeah,
we care.
yep,
That's it.
yeah, and it sucks that he's had to have a surgery and a subsequent ACL reconstruction. But I think if we don't talk about these things, we sort of live in this world where we are probably giving false hope to all our athletes too, because if we don't share these experiences to say, hey, look, we've got great outcomes that can be had, but unfortunately we're going to occasionally have some bad outcomes too, where you might have an instability episode with your non-operative rehabs, and sometimes they may get worse, and that's the risk. Now, as long as you're having these open discussions, then you're doing your job.
Yeah, you're doing the best you can. Have you heard of an athlete called Shandor Earl, NRL athlete?
Yeah, I know him reasonably well.
Well, okay. To share a quick anecdote, Christian Woodford from Woodford Sports Science Consulting, he managed his return to
Yeah,
sport after
yep,
his ban. And as you would have heard, and for those listening who haven't heard, Shandor did his ACL many years before that when he was younger, right? He was getting
mm,
in the best shape of his life. I was there documenting that process in the return video series that
yep,
I created. So I got to see the week to week and really get detailed and see
yeah,
exactly how these guys work. And I was in the facility when Christian got a phone call after Shandor was already going back to prepare for the season. He got his
yeah,
phone call and Shandor said, man, I got some bad news. I did
mm,
my ACL again. And I was there and Christian just broke down, right? And he's talked about this. So I know he doesn't mind me sharing it.
yeah,
And I'm
yeah,
like,
yeah,
that's a clear case of like, he felt bad, he felt guilty, he felt confused. Like, we did everything we could.
yeah,
And I just tried
yeah,
to tell him it's not your fault, man, because at the end of the day, it's like, we were there. Like, we got the whole thing documented. Like,
yeah,
sometimes you do everything you can and
yeah,
just shit happens.
yeah. That's it. That's it. I think if we take that those examples to heart, we won't sort of progress as humans. We probably won't get better as coaches, and we won't get that thicker skin that we need sometimes to keep pushing ahead. Because if we allow that one experience to hold us back, we won't be looking after everyone else very well. Yeah, no, I remember that case, and I worked with the Melbourne Storm. I did some work experience with them at the start of last year, and I talked to Sandor a few times about his ACL journey and got to meet him a few times and discuss that. And I know Woody reasonably well too. So yeah, I remember, and it was I was gutted at the time for everyone involved. It was a sad case, but look at Sandor now. He's doing great things, and
He
yep,
is.
yep.
That's an awesome story. But I want to be respectful of your time, Mick. Like, I'd love to keep chatting if you're free and
Oh,
available to. Are you
yeah,
still
yeah.
good?
I got I got a little bit more time to go. Yeah, all good.
Awesome.
Yep,
If you got to
yep.
go, just let me know.
Mm.
I wanted to talk about well, get your thoughts on it. Upper cross, lower cross syndrome. I don't know if you use it as a tool previously or you look at it as
Mm.
a diagnostic tool now, or it's just, is it a real phenomenon or just some like biomechanical scapegoat? Because now I'm starting to hear both sides of the story and I'm trying to pass out the truth. What are your thoughts on it?
Yeah. I don't know. I don't get syndromes and trains and all that kind of stuff. I don't know if I'm just not smart enough to understand it. I just don't do it. Like, if I see an impairment, I work on it. and I don't know if that's a good thing or a bad thing, but I just do what things that work for me. I don't, to be honest, to answer the question, I don't know if it exists or not. I don't tend to sort of let it dictate my rehab programs or my sessions. I know some coaches and physios like to sort of do. But for me, what works well for me with my, I guess, my rehab planning, I just keep it pretty simple. I keep it simple. I focus on the key lifts. I work on impairments. I make sure unilateral training's in there. I try to just work on those really all important 99 percenters. Get strong, load up efficiently. Get good sleep. Get fit. Get conditioned for the demands of the sport. Eat well, try to minimize stress, all those kind of things, and just get the job done, and consistency. Like, yeah, I think there's a lot of confusion out there, unfortunately, that can make clinicians a little bit confused as to what they can do, and it can sometimes make people freeze when it comes to programming planning. So I keep things simple. Yeah, yeah,
Look, that's great because I think, what a lot of people, even yourself, don't know. We're actually redesigning our whole Cert 3 and 4 and trying to make it the most comprehensive thing that is available in Australia. And that
mm,
involves asking these questions: what is important, what is not? And I
mm,
think just the fact that a professional with such your experience even approaches those types of things in that way, like very foundational, simple, it makes us think, well, what is it for? How useful
yeah.
really is it, or is it just adding more confusion to the pie?
Yeah, yeah, I do wonder about that, especially yeah, you see, I see a lot of stuff on social medias with certain types of bands or exercise equipments or whatever it may be. But I think if you just sort of stick to the basics, just good consistent exercise programming, um, fundamental movements and lifts, and good programming and progressive overload, like that's just going to be such an important part of their rehabilitation journey. And I think we sometimes do get ourselves lost in a lot of the cool stuff that's out there on the internet. And I think if we just stick to the main basic stuff, we're going to do a great job for our patients and athletes.
Well said. Well said.
Yeah,
The basics work. The fundamentals
yeah,
work.
absolutely.
We try and make things way more complex than they are, don't we?
Yeah, yeah, I think so sometimes. Yep.
I've got a question from a Facebook Live. Someone is listening. Joe Ryan. He's asked, should the PT and S&C coach be doing check and retest methods if their client has a mobility/joint capsule soft tissue restriction?
Um, oh, you can if you want. I guess what are you going to do with it if you see it? Yeah, look, if they've got a stiff knee, if they've got a stiff hip, stiff ankle, yeah, you can assess it to see if it is stiff compared to the other side. I guess then the question asks, what are you going to do with it, and is it within your skill set?
Mm.
Is it inside your scope of practice?
Well,
For
let's
sure,
talk
like
about that. Like,
yeah,
is that insulting to do stuff like that? Is that disrespectful? Is that
yeah.
outside the scope?
If they've got the training, if you've got if you've done some postgraduate courses or you've done some weekend workshops to help improve mobility at a joint or within a tissue, yeah, as long as it's operating within your profession's scope of practice, and you're skilled in that area, yeah. I mean, I don't do a lot of manual therapies myself at the best of times, especially once again, probably because it's biased. I'm biased towards that ACL reconstructed patient who's 4 months, 6 months post-op struggling with their rehab planning. I don't necessarily see a need to do a whole lot of knee mobilizations or ankle mobilizations or hips or a lot of soft tissue work. What that person's coming to me with is frustration because they don't have a plan. So I just talk to them about their plan and get that plan in place and get them moving forward. So I can't speak for the wider physio community here, but yeah, look, if you've got the skill set and it's within your scope of practice, yeah, by all means, I don't particularly have a problem with that.
Well, that leads in really well, like, because there are a lot of trainers and young coaches who claiming a skill set in rehab or injury prevention, on their CV, for example, or in their bios. But what do you think should be the minimum level of knowledge, qualification, or experience before competently and confidently claiming that you are well versed in injury prevention and rehab?
Yeah, yeah, it's a good one. Look, I think I think you need a lot of years and a lot of skin in the game, really. I think from a rehab perspective, I think if you're if you're a personal trainer, maybe within second, or an S&C coach within 2 or 3 years upon graduating, I think you may not be experienced enough. I think we're going to be sort of dealing with someone that's been around for 5+ years, and working consistently with injured athletes.
Yeah.
Yeah, look, I mean, even now, like, I mean, I've been lucky enough in the last, 4 or 5 years to largely see ACL injured patients. I'm seeing, probably when I'm working face to face with patients, and before COVID hit, I was sort of seeing somewhere between about 30 ACL reconstructed patients a week. So I was seeing a fair few, and so I think that's allowed me to become, um, very experienced and confident in treating ACL injured patients. That's taken a long time to get to that level. So yeah, look, I think it takes, yeah, if to give you a time frame, I'd say 5 years. I think you'd need at least 5 years to be able to call yourself a really competent rehab coach, and to, or a injury prevention coach, or whatever it may be. But
But not
also,
just 5 years of coaching, right? It's like, because then I could call myself that,
yeah,
but I don't feel competent to do that because my
yeah,
quality of my hours have not been majority in rehab and
that's
injury
right. Yeah,
management. So talk about
yeah.
like the quality of what the hours are is important.
Yeah, absolutely. Like, I think, the last podcast I did before is like the jack of all trades, master of none. Like, I think if you've got a passion in a particular area, like, I mean, it's hard to, depending on where you live. Like, I think we're lucky here in Melbourne, and I'm very lucky to be living here in Melbourne, and to be able to see so many ACL injured patients. Now, if you lived in the country, you're not going to have that same, um, amount of ACL injured patients walking in your door each and every week. I certainly wouldn't be anyway. So you do need to be a bit more of a generalist, depending on where you live and work. But I think if you want to be a rehab coach, for example, then you sort of need to be aligning yourself with a physiotherapist, for example, and receiving referrals, or a doctor, or a sports doctor, or an orthopedic surgeon, and you're receiving referrals from acutely injured patients all the time, or acute, post-op surgical stuff all the time, and seeing at least probably 20 patients a week, at least, of, rehabilitation. And if it's a variety of things, great. If it's a lot of hips and knees and ankles, great, even better. But if you're seeing it, backs and shoulders and all sorts of different things, but you're helping to rehabilitate a patient with the low strength base and the low fitness base, and you're taking that person from the absolute basement of their performance through to the floor and then to the ceiling, to quote Tim Gabbett's sort of, analogy there. I think you need to be looking after a lot more people in the basement, and helping them out of the basement up to the floor, if we want to call ourselves, probably a good rehab coach.
Right. Well said. But then there's this, you know, physiotherapy, at least high quality ones like yourself seem to practice that, it's best done on the gym floor rather than on the consulting table. Like, you don't do a lot of manual therapy, which then leads into, how do you think the fields will merge? Strength and conditioning, personal training, and physiotherapy, exercise science. Do you anticipate them to merge, or do you also always anticipate there to be them separate fields? We always just refer to each other and learn from each other.
Yeah, I think they'll always remain separate, and I think, yeah, I think that will, and I think the physiotherapy bread and butter is still very important. Like, our ability to assess and diagnose musculoskeletal conditions. And obviously, physiotherapy, we've got more than just being a musculoskeletal physio or a sports physio. We've got great physios working in hospitals on the cardiorespiratory wards and the neuro wards, and with geriatrics and pediatrics and stuff like that. But I think from the private practice physiotherapists, I think we've still got that important role to play in assessing and diagnosing a lot of, injuries, particularly acute ones, chronic ones, as well, and managing that. But I think the what we're starting to see a trend in now is the physiotherapist who's got also a clinic with a gym,
Hmm.
and that's a wonderful resource to have, and that's where we've got the ability now to, really use exercise professionals, personal trainers, S&C coaches, exercise physiologists together to help better our athletes and patients that we're looking after, rather than sort of keeping it very fragmented and within silos where, the physio will only look after them for the first 6 to 12 weeks, and then say, okay, here you go see the exercise physiologist. There's certainly some merging of phases and merging of time points where I think we need to learn to work together as a whole, rather than dividing ourselves and trying
Absolutely.
to.
How do we do that? How do we optimize this process, especially the new personal trainers that we work with, that we teach? How do we develop this strong allied health network together?
Yeah, yeah. I don't have the answers. I don't think. Look, I think importantly, if you do have an interest in the area, and I get a lot of people come to say, look, can I shadow you for a week, or can I be mentored by you, or can I come and see you in the clinic and have a day here, have a day there. I think that's a great way to start opening up those conversations with personal trainers and S&C coaches and young physios. And I think that's kind of where we need to go with it, to understand each other's roles and each other's skill set. Like, I think if if you've got a physio in your local area, go and see what they do for a day. Or if you know a physio that's got a passion in the area that you also enjoy treating and looking after, go spend a few days with them and get to understand them, get them to talk shop and showcase your talents as well. Like, if we don't know what you can do, then we're not going to refer to you, kind of thing. And we're not going to be able to refer to you, because we need to sort of know that we can work together. We can understand where your philosophies lie and what your sort of, treatment methods lie. We need to be sort of working together as a team, and you got to understand where we're coming from as well. So I think that's important, particularly for the newish grad personal trainer or an S&C coach or exercise physiologist. I think there's some ways forward there, just by simply spending some time and having some discussions with the physio. And I think the best place to do that is on the job, rather than sort of, meet up for a coffee necessarily, or, like, actually see it in real time, get them to see what a treatment session looks like or a rehab session looks like, and discuss things as the person's working out in front of you. I think that's probably the best time to learn.
I think it's phenomenal advice. That is super practical because everybody can hit up their local good physio, and
Yeah.
everybody can hit up their local gym on the other side. Physio
Yep.
can go shadow the coach, coach can go shadow the physio. We'll learn from
Yep.
each other, develop a
Yep.
network,
Yep.
friends.
Yep. There we go.
That's it.
Yeah, it doesn't take that much. Like, one of the simplest things I did when I moved to Melbourne, and probably taking it the next step above, was like, when I moved to Melbourne, I didn't know anyone down here, and I didn't have a network of orthopedic surgeons that I was looking to get referrals from. So I went and watched 4 or 5 orthopedic surgeons do knee surgery, and hip surgeries and shoulder surgeries, and just to talk shop and let have a chat to them whilst they're on the job. So I think that's one of the simplest things, that anyone can apply that method into a different field. And I think if you're looking to work with a physio and you want to work with your athletes, with your physiotherapist, that's the simplest way forward, is put your hand up and get in contact with them and say, hey, look, can I spend some hours with you? Can I come and see you with some patients? Or, can I actually sit in on the consultation with my athlete that I'm looking after? You're looking after him as well, or him or her as well. Can I come in and sit on the consult so I can understand what the rehab plan is, so I can then put it into practice outside of your face-to-face time? I think that's how relationships are developed, and that's how we're going to grow as a profession, for both sides of the professions.
Agreed. That you well said. In case of you personally, if someone comes to you and
Mm.
they look up to you, they want to be, on the level that you are and aspire to be, a Mick Hughes type of coach and physiotherapist.
Mm.
Would you go back and do your path differently, whether it's your tertiary education? Would you tell that younger Mick Hughes or someone who wants to be in your shoes that, hey, maybe you shouldn't actually do this or do that or do all this education in a degree? Maybe it's better to do these certifications in this or over here. What do you think?
Yeah, yeah. Look, I think there's a need for some formal qualifications, but I think and look, I finished physio school, and within I think 3 years later, I was doing a postgrad sports physiotherapy, and then that led on to the masters and that kind of stuff. But I think all along the way too, I've tried to seek out, where possible, volunteering my own time to try and talk to talk to, spend some time in the operating theatres, watching orthopedic surgeons do their work, or try to shadow some more experienced physiotherapists in the way they practice, or spend times and volunteer time at my own merits, knowing that like this time I'm going to volunteer my own time to go and watch a sporting team do their thing, so I can sort of get a better understanding of the sport's demands. I think that would be something I wouldn't change, because that's kind of like the stuff that I do. But I think there's this I think that's where we all need to be going as new grads. If you've got a thirst for knowledge and you want to be that type of physio or that type of coach, we need to be proactively seeking out that mentoring opportunity or that experience, and understand you're probably not going to get paid for it. Like I'm not at all saying go and take an internship at a professional club where you get flogged for 30 hours a week for no pay. Like I hate those positions that are advertised, and I think it sucks to the wider community. But if you want to learn something, go and seek out people who have experience in their chosen field, and try to get to know what they do, and how they've become who they've become, and share that information, and sit back and watch. I think that's a very simple strategy that we can all do to better ourselves. And I still, where possible, try to go out and still watch ACL reconstruction surgeries where I can, and to still spend time with some more experienced physios than me, and talk shop. So I think no matter how old we are in our field, and in our profession, there's still an opportunity to grow. Like some of the best, I've been lucky enough to spend some time with Tim Gabbett and listen to him talk, and share his experiences. And my good mate Randall, who's 10 years my senior, like his experiences working in elite sport as well has been amazing. But also those other softer skills too that you learn up along the way. I think that's a valuable lesson to learn as time goes on, is those communication skills and those softer skills. I think they're the things that really come with time. Um, yeah, so
Has there been one in particular that was a previous kind of weakness, hole in your bucket that you've had to realize and fill?
yeah, oh, definitely. The softer skills, like just that, what we talked about before, like that ability to adapt a program to suit the person who's just busy,
Yeah,
that person who I just now give 2 exercises to, like that's something that's come along with time. And if, 10 years ago as a new grad, I was pretty regimented and fixated in my programming design and my rehab design and all that kind of stuff. Because I didn't have kids back then. I didn't have a wife. I didn't have a busy job. Like I now get it when I meet a person for the first time and they're in their mid-30s, they got 3 kids and a busy job. Look, I now understand that time is very precious. So, you try to sort of fit in your plans that's going to help them within their chaos. So, that's being adaptable, and they're the softer skills that I've learned over time, is to be flexible with that side of things.
yeah, that's so important. I think, especially as a younger coach, to hear from someone so much more experienced than yourself, because we get excited to share, and we don't have the empathy and compassion and understanding of, like you said, you had to learn it when you became a father and had a family. But once you hear it from something, it's like, yes, we have to remember that when I'm working with that clientele who is working 50, 60-hour weeks, has children, or is just generally more highly strung and stressed, it's a time to adapt. And
Yep.
that's what
Yep.
all of us are having to do now during this pandemic.
Yeah.
Thankfully, allied health professionals, as far as I understand, can continue to deal with their patients.
Hmm.
Personal trainers, gyms closing, different.
Yeah.
How do you think? How have you adapted? How can people adapt to this time? What is the? I mean, we talked about it before we went live. What's the
Hmm.
opportunity here in the adversity where people can learn from and thrive under these new conditions?
Yeah. Well, I think yeah, I've sort of been a bit torn through this. Like I've probably lost a little bit of my face to like what I'd normally see in the clinic and the patients that I was offering telehealth services to. Like I probably have lost a fair bit of that patient load. Now, whether or not they just got better by themselves or are just happy just to let this all ride out, until it's all over, that's fine. But I think the opportunities that arose, especially for me during this time, was to um, gain more clientele outside of Melbourne. So I've been consulting with patients interstate, overseas during this time, and doing a lot more telehealth consultations with people that I've never met before. So I've grown that sort of side of things. I've got 30 new patients that I've picked up along the way over the last 2 months. So that's been a really cool thing to come out of. The silver lining to come out of this is I've been able to sort of to do that. But I think for all of us, I think there's certainly that what we're dealing with now may be a new normal for us all. We may be able to deliver telehealth services or personal training services or S&C services online. And I know that's been around for a long time. There's been online coaching and all that kind of stuff. I don't know how effective it is from a personal training perspective because you may not be able to, touch and cue and all those kind of things. But from a physio point of view, a lot of the stuff that I'm doing online is probably no different to how I'd normally do it in the clinic anyway, with good quality information, good education, information, and you can see how someone moves quite nicely with on a video in front of you. So there's just that sense of being adaptable to our current way of life and sort of think big picture, like that's one opportunity here for everyone here is even if you're based in Melbourne, why contain yourselves to your geographical boundaries now? Showcase your talents, interstate, worldwide, and, start looking to attract people, for your services, you know, over internationally, what, don't, think big picture here. I think there's an opportunity for that, with a little bit less of face-to-face stuff going on. But you've also too now got this opportunity, if you're finding yourself a little bit more quieter from the face-to-face stuff, to allow yourself to read more,
Mm-hmm.
to listen more, to learn more, and to share that knowledge as well. Doing stuff like this, writing blogs, doing that kind of stuff. Like I think there's a good opportunity there too in the right individual. I tried to do that. Like I tried to be really productive in this time, but I think in the end I was getting burnt out a little bit, trying to sort of keep myself busy and trying to be really productive when, I've got two young kids and a busy wife and a busy life around me. Like I was just got to a point where I thought, you know what, I'm just here for survival now. I just want to get through and just make sure we come out of this in a good place. And I think too, like if you're not productive, don't feel like you need to be super productive through this time, because this is quite tough for some people as well. So, in that setting too, maybe it's just an opportunity to sit back and just learn and reflect, especially if you can't produce, if you're just too busy, maybe listen to more podcasts or maybe do some more reading outside of health, maybe look at some different authors, maybe read different books that you normally wouldn't read rather than textbooks. Maybe just look at, maybe some business side of things or maybe some philosophical side of things, or, just do something a bit broader from what you currently would sort of absorb day in, day out. Because I think there's a few of us out there too that might feel the pressure to produce stuff when we just can't.
Yeah.
So in those people, just get through. Do what you can, survive, get through, read, get better at the end of it. But for those that do have the ability to produce, go for it, go nuts. Do whatever you can do, but also too, don't be scared to go big, as well. Go big and go broad.
But having the self-awareness to know
Yeah,
which one you are,
yeah, exactly.
and you
Yeah,
may feel different in a month.
yes, that's right. Yeah, like the first few weeks, I was like, I'm going to do this, I'm going to do a webinar, I'm going to do this, I'm going to do that. 2 or 3 weeks in, I'm like, oh, man,
Yeah.
like I'm just getting frustrated here because I can't do what I want to do. And so I just went, no, I'm just going to put everything to bed. I'm just going to do what I can. I'm going to just chip away slowly at things, and just worry about sort of looking after my own sort of personal health, my own family, look after my own patient load that I've got. I've got new ones coming in. That's great. I think that's, for me, that's where I've gone. But like you were saying, you've been able to do lots and lots of different things, and that's great. And I think there's be a lot more people like you out there that've got that opportunity as well. But have that self-awareness to know which side of the fence you're
Yeah.
sitting.
I
Yeah,
mean, for me, it's like it depends what you want out of this life. We're going to get a bit philosophical here, but it really depends. Like, what do you want to happen? If you want great things to happen, you have to do things regardless of how you feel. I believe that. Otherwise, I wouldn't do half the things I do, because a lot of the times you don't always want to do the thing, but you have to do the thing because it's good for you, because it's going to be short-term pain, long-term gain.
yeah,
I mean, that's at least what I've learned. And then I wanted to also ask you before we finish up is are you content, Mick Hughes, like as a professional? Like, I always wonder when people are in the industry for a long time, you know, where do you go from here? Or do you not even think about that? You know what? I just focus on my clientele day to day, week to week. I'm content. I just want to do my service best I can.
Yeah.
Or are you trying to build something bigger and better? And I don't know.
Yeah, yes and no. Like from a physio perspective, I'm pretty content, but I'm also self-aware to know that there's a danger in being content, and if you just do what you do all the time, you'll quickly fall behind. And I think there's just in this current day and age of information sharing and lots of research being produced, particularly with ACLs, there's new stuff being published all the time. So I think importantly for me, I keep it abreast of that to make sure I'm still keeping up and being a best practice clinician. Because if I stop reading journal articles today and just keep practicing the way that I normally do, in 2 or 3 years' time, I'm going to be behind the eight ball. I'm going to be out of date. So I need to be up to date and keep going and keep growing and keep learning and adapting all the time to make sure my patients are receiving their best care. So I guess professionally for me, I'm not seeking a PhD or going out and trying to be a professor or anything like that. And I think I just want to look after my patients in the clinic and do the best I can for them. I think broader, from a business perspective, yeah, I've got goals of trying to grow. We've got Learn.physio as our online learning platform to share masterclasses and videos. And from that point of view, I really want to see that grow and be a platform that people will go to seek online learning opportunities
Can you talk
because
about what that is? I'm not familiar. And I think, a few
yeah,
people won't
yeah,
be.
no, it's fine. So it's Learn.physio. Basically, it's that's the website address, Learn.physio. It's
Oh,
basically a platform where at the moment we've got some online masterclass videos. So we've got two ACL videos, one ACL reconstruction and one non-operative masterclass. And we've got Tim Gabbett. I sat on the couch with Tim Gabbett. We talked about load management. And so basically we provide a 2 to 3 hour video discussing the latest research with experts in their chosen field, and people can just watch them anytime, anywhere, as long as they've got an internet connection, for professional development purposes. So if you're a personal trainer, S&C coach, physiotherapist, exercise physiologist here in Australia, you can get professional development points to watch these masterclass as well. Instead of having to go to a weekend workshop or go to an evening lecture, you can just jump online and watch the videos and maintain that development. So we've just got 3 videos there at the moment, but we want to see that grow. And our philosophy to that is we want to have 2 experts sitting on the couch talking about the research, but also from their practical experiences as well. And that's our website there, which we want to sort of see good in years to come. And I think now is, I guess, critical time as ever, where you're not going to see weekend workshops for potentially some time. That's moving forward into the future. People will be seeking out these online learning opportunities a little bit more frequently. So hopefully we can sort of allow that. Not that we're the first in the market. There's many more other people out there in the market as well. But we want to be that point of difference where we've got 2 people talk about their own experiences and sharing high quality information to the masses.
oh, that's awesome. I'm looking at all the variety here. It's like
Yeah,
multi-hour conversations you're having with experts.
yeah, like that. Yeah, exactly. So the non-operative one was fantastic. I got to sit down with um, Olvenor, who's an ACL expert in post-traumatic osteoarthritis, and hearing him talk about his experiences and research in the field for over an hour was great. And hearing about Brooke Patterson's experiences working with AFL Women's and their injury prevention program design, that was fantastic. But also research around that space too was fantastic to hear. And obviously talking shop with my mate Randall, sitting on the couch with Tim Gabbett for a couple of hours talking about Luffman and some of the myths about that. That was wonderful. A huge insight as to load monitoring and training loads. That was fantastic. So that's kind of the go. We want to grow that and sort of take it outside of just ACLs and into shoulders and hips and knees and
That's awesome.
hamstrings and all sorts of different things.
That's a
So
great
yeah,
resource. I didn't know you did that.
but there, that's where we want to. Yeah, but that's where I think from my own personal perspective, that's where I want to see that growth and development. But from a clinical point of view, just need to keep busy, keep on top of it, so my patients are still receiving their best possible care as years to come.
Awesome. I appreciate that, Mick. And I guess the last thing is the cliche, but important. Young coach, allied health professionals, and PTs now entering the fitness industry. What do you tell them? How do you overwhelming with all the stuff there is out there?
Yeah,
Unlimited opportunity though, but it's hard. What do you tell them?
yeah, yeah. Look, I think the big one is just be patient. Don't try to. I think that was my biggest thing as a new grad was I wanted to be on top of my field, on top of my game within 3 years, 5 years. Like it takes time to develop the skill set that you need to be a great clinician or a great helper for the time. Like I remember, 1 year out, 2 year out, thinking I could be the head physio for this sporting club. I was working up in North Queensland, and I was like, yeah, I could do this. I could be a professional. I could be the head physio for any sporting club. I've got the skill set. I know what to do. Like it's only now, like really up until a job at Collingwood with the netball team, it wasn't until then that I felt like I actually had the skill set
Hold on.
to
How
be
many
that
years in
person
the
and do
industry
it.
did it take for you to come to that?
Well, I was a physio for 6 years, but I'd been an exercise professional for over 10. Like I finished back in 2002. I completed my physio studies in 2010. And it wasn't until 2016 where I thought, you know what, I actually do have the skill set now, that head physio for a sporting club. Um, but, like when I was 1 year out, 2 year out, I was like, I could do this. But in reality, rubbish. Like if someone offered me a position to be the head physio for a professional club, or even a part-time physio at a professional club, if I was my first year out or second year out, completely rubbish. I would have been shown the door after a year, and I would have been disgruntled, and I would have never worked in sport ever again. But I think importantly, you remain patient. You learn as many things as you can along the way, and allows you to grow and develop those really strong skills. And it also allows you to failures so that you can get better as a person as well. So you know what works with athletes, you know what works with different kind of people, and allows you to grow. And I think from a new grad perspective, I think key message, just be patient. Be patient. Don't expect to be on top of your game, on top of your field for many, many years down the track. And importantly, take your time and just be patient. You just work hard, be patient, and you'll get the rewards later.
I think that's a great lesson in life, right there.
Yeah,
It
100%.
transcends professions. But thank you so much for doing this, Mick.
No worries, Alex.
We know guys like you are getting asked left and right for podcasts. It's like everyone's having a podcast now, including myself. So it's very appreciative of your time. Where can people? Yeah, go ahead.
That was good. It was a really nice chat. It was like and the one before this morning, like it was
You did another
nice
one
to
today?
sort of, yeah, with some guys over in the States. But it was good. It was good. Like from both these this morning have been fantastic. It's just been nice. It's been deep conversations. It's been philosophical stuff. It's hasn't been so clinical and technical. It's been some of those softer things. It's been really really enjoyable to have a talk. So thanks for asking me to come on, Alex. It's
Of
been great.
course, we'd love to have you on again in the future. But Mick, for now, where would you tell people to go? Where can people find you? Do you have any asks of our audience? Any last comments, or where can people find you?
Yeah, no, look, yeah. If anyone's, if they haven't, if they're not following me on Instagram post pretty frequently there. So my Instagram handle's mickhughes.physio. Same thing with Facebook. If you're on Twitter, all the social media sites, I've got a whole heap of stuff that I share. They generally are the same things, just rehashed across different platforms.
Yep.
But YouTube, I've got a YouTube channel which has got a whole library of exercise videos. I think I often get people asking me, "What's this? What kind of exercise can I do for this, this, and this?" And it's like, well, go check out my YouTube channel. So that's often ticks a lot of boxes for people. So don't forget to check that out. And of course, if you're looking for some online education, jump online to learn.physio and check out some of our masterclass series there.
Awesome.
And if you're going through ACL rehab, we've got the ACL Melbourne ACL rehab guide up online, free and online these days. So it's melbourneaclguide.com. So yeah, a few things for people to
Is
check
that
out.
that's early stage to what is the timeline on that?
The ACL guide, it takes you from pre-operative all the way through to return to sport. So yeah, covers all the bases in different stages of rehabilitation. So
That's free.
yeah, it's free. We used to sell it for about $5. You could download it for about $5 a pop. But now we've partnered up with La Trobe University.
Mm-hmm.
We've partnered up with them. They've turned it into a website, which we're now, obviously with patient consent, we're using some of their de-identified data to collect research as well. So if you jump on to melbourneaclguide.com, patients will need to sign up, the physio will need to sign up, and then they become linked. And then the physio will enter in the data for the patient so we can, learn more about ACL injuries to help improve outcomes in the future.
That is awesome. I got it up now. So many resources. Much appreciate that.
There you go. So give you some reading and something to think about over the next few days and few hours.
Mick Hughes, thank you very much. I hope you and your
Thanks,
family
Alex.
stay well.
Cheers, mate. Yeah, all to you, mate. Stay healthy.
You too. Speak soon.
See you, mate.
See ya. All right. That is Mick Hughes, ladies and gentlemen. I'm going to give you guys a little bit of a taste of what's coming next because we do this every Wednesday. So let me show you exactly what's coming next. What we have is, for those who don't know, we put all of these on, you'll find these on Spotify, on podcast platforms. All you got to do is look up Orphic Education and you'll come up with all these different podcasts that we're going to put on audio versions as well. You can see we've done 4 so far. This is our 5th one every Wednesday. You can see I'm listening to some very nice Spanish music over here, but don't worry about that. That's a topic for another day. And then I'm going to give you guys the website that if you want to know all upcoming, you want to be notified of any future webinars, coaches roundtables that we do. All you got to do is go to Orphic Education /webinar-Wednesday, and you will find exactly what is upcoming, our past guests. For example, today was Mick Hughes. Next week we're having Tim, Dale, Costa Drac talking body composition, athlete training. And then you want to be notified. All you got to do is enter your details there. Boom, boom, boom. And you'll get notified. And then we also put it on YouTube as well, because YouTube's a great platform for user interface. You can make it faster, slower, whatever you need, and watch it later. So that's Orphic Education on YouTube. That's what we do. That's who we are. We're a education company that deliver certificate 3s and 4s in fitness and are trying to change the game in that. Redesign and make the most comprehensive certificate 3 and 4 in the country. And elevate the standards of this industry. Just in case you didn't know, if you're new to Orphic, that's who we are. That's what we do in a nutshell. If you guys got any questions, comments for the next ones, any requests of guests, let us know. Put it in the comments, DM us, email us, and we'll do our best to get them on. For now, thank you guys so much for listening, watching, and we'll see you next Wednesday.